Hello, my name is Jamie Watkins, and I'm a nurse practitioner at West Cancer Center, and I'm going to present to you on updates in breast cancer. So, targeting mutations in metastatic breast cancer is important, and it can be useful in guiding our therapy. This is a study looking at ESR1 mutation in patients who were already on first-line AI and CDK4/6. They were testing at intervals to see when the ESR1 mutation would show up, and trying to see, how this could be useful in guiding our therapy. And we have some new therapies on the horizon for ESR1 mutations. So looking at a new generation oral SERD called camizestrant. So this patient population in the SERENA-6 study was looking at ER-positive, HER2-negative advanced breast cancer patients. All of them had received an AI and a CDK4/6 inhibitor as initial therapy for their advanced breast cancer for at least 6 months. They were randomized 1-to-1 with camizestrant and continuing the CDK4/6 inhibitor versus continuing the AI and the CDK4/6 inhibitor. Primary endpoints were progression-free survival. And there was a median progression-free survival in the camizestrant group of 16 months versus 9.2 months in the AI group with CDK4/6 inhibitor with both. And then looking at time to deterioration, status and quality of life, there was a median time to deterioration of 23 months versus 6.4 months. And that was the 23 months in the camizestrant group versus the 6.4 months in the AI group. And then safety profiles, they were very similar between the two groups, with the cytopenias being more prominent for both the AI group and the camizestrant group with CDK4/6 inhibitors in both. And then of note, there was a photopsia seen in the camizestrant group that was not necessarily ever seen in the AI and CDK4/6 inhibitor group. This was the leading non-hematologic AE in this group, but of note, it was temporary and it was reversible. Vepdegestrant is a PROTAC, an oral agent that we're looking at. And this is a study comparing the vepdegestrant to fulvestrant in this population with an ESR1 mutation. Primary endpoint was progression-free survival. And notably, the patients who had the ESR1 mutation did seem to respond better to the vepdegestrant than the fulvestrant. And as far as AEs with the two, there were more AEs noted in the vepdegestrant group versus the fulvestrant group, as you can see here. However, very few led to treatment discontinuation or dose reduction. Okay, targeting TROP2 in metastatic breast cancer. So TROP2 in general is associated with larger tumor size, recurrence, more aggressive tumors, overall shows a worse prognosis. Of note, it is more common in triple-negative breast cancers. However, in general, it is commonly expressed in malignant tissues. And so we have several drugs that are available to us in targeting TROP2, the antibody drug conjugates, and some of these most people are familiar with. However, we do have some new ones on the horizon. And so of note, these drugs also have what they call a bystander effect, which allows them to diffuse into surrounding tumor cells. that may have lower absent TROP2 expression and also kill these adjacent tumor cells as well. So that's been useful in using these TROP2 targeting agents. So the ASCENT trial, this is an older one most of you are probably familiar with. It looked at triple negative breast cancer patients, and this was for sacituzumab govitecan, and then treatment of physician's choice, okay, with primary endpoints of progression-free survival. And so you can see they also kind of divided this into patient populations of those without brain mets and then the full population of including those patients with brain mets, and both showed benefit with median progression-free survival of 5.6 months versus 1.7 in the group without brain mets, or 4.8 months versus 1.7 months in the group that included patients with brain mets. Adverse effects with these were similar with both groups. However, with the sacituzumab govitecan group, there were more cytopenias seen, more GI fatigue and alopecia related symptoms. The ASCENT-04 and KEYNINE-D19 study looked at previously untreated, locally advanced, unresectable, or metastatic triple negative breast cancer patients that were PD-L1 positive. Okay, so this looked at the sacituzumab govitecan plus pembrolizumab or chemotherapy plus pembrolizumab, and the endpoints were progression-free survival. And so the sacituzumab plus pembro group demonstrated a statistically significant and clinically meaningful improvement in progression-free survival versus chemo and pembro. The progression-free survival were similar when assessed by the BICR as well as investigator assessment, and both showed a positive trend for the sacituzumab plus pembro group versus the chemo plus pembro group. Also noted a substantially longer duration of response and higher overall response rate, including an increased complete response rate in the sacituzumab plus pembro group versus the chemo plus pembro group. In the ASCENT-04 trial, the safety profile. So despite the longer duration of treatment with the sacituzumab and pembro group, rates of greater than grade 3 AEs were similar for both groups, and treatment-related AEs leading to dose reduction or treatment discontinuation were lower with the sacituzumab and pembro group versus the chemotherapy and pembro group. And both were related, very similar to known AEs of both the sacituzumab and pembro separately, and neither were seen to be worse in combining the two. So TROPION-Breast01 looked at patients with hormone receptor positive, HER2 negative breast cancer, and the HER2 negative defined in this group would actually include what we now call HER2 low, which is the IHC 1+ and 2+ group with ISH negative. This was looking at Dato-DXd versus the investigator's choice of chemotherapy, with the endpoints of being a dual primary endpoint of progression-free survival and overall survival. And what we saw here was that progression-free survival median was 6.9 months versus 4.9 months in the chemotherapy group. So there was definitely a trend favoring Dato-DXd for progression-free survival as well as overall survival. And then they actually broke this out too for patients who presented with brain met at study entry versus no brain met at study entry. There was still some benefit seen, however, it was smaller in the group with brain met on presentation to the study entry. So safety profile, the most common treatment-related AEs leading to dose interruption in the Dato-DXd group was fatigue, infusion-related reaction, ILD, and stomatitis, but this was less than 1%. And in the chemotherapy group, it was neutropenia and leukopenia. There were no treatment-related AEs that led to discontinuation in either arm. There was one treatment-related death in the chemotherapy arm due to febrile neutropenia. So in the OptiBreast-01 study, this one was looking at patients with locally recurrent or metastatic triple-negative breast cancer. And this was looking at SAC-TMT versus the physician's choice of chemotherapy, and with a primary endpoint of progression-free survival. And so progression-free survival by investigator assessment, median survival, progression-free for survival was seen at 6.5 months in the treatment arm versus 2.6 months in the chemotherapy arm. And this study crossed the overall survival efficacy boundary with Dato-DXd. Another interesting study, I think, is this pre-med study, looking at how we can prophylactically treat the AEs that come along with some of these treatments that we're offering. And in particular, this one looked at sacituzumab govitecan and the known AEs of diarrhea as well as neutropenia. And so what they did here was combine this prophylactically treating with growth factor and loperamide. So giving a short-acting growth factor Q-day for 2 consecutive days, 48 hours after each administration of sacituzumab govitecan, along with loperamide, 2 milligrams POVID or 4 milligrams Q-day during the first 2 cycles. And you could continue these as needed, in subsequent cycles. The primary endpoint was incidence of grade 3 or greater neutropenia or incidence of grade 2 or greater diarrhea. And what they found was that the prophylactic administration of the growth factor and loperamide resulted in a clinically relevant reduction in the incidence and severity of sacituzumab govitecan-related neutropenia and diarrhea. And this combination could help mitigate dose reduction and treatment interruptions, as well as permanent discontinuation due to those treatment-related AEs. All right, looking at HER2 low and ultra low metastatic breast cancer. So what is HER2 low and ultra low? So IHC 1+ and 2+ are considered HER2 low, and then IHC 0 with incomplete membrane staining is considered ultra low. And if you can see these slides looking at these tumor cells, this ultra low category, there's one little tumor cell here that has some membrane staining. And so that categorizes that as ultra low. And then the Destiny Breast 06 patient population, they discovered that approximately 85% of hormone receptor positive HER2 negative metastatic breast cancer patients actually fall into this HER2 low or ultra low category. And so this opens up some treatment options for us. So the Destiny Breast 06 design looked at HR positive metastatic breast cancer, HER2 low or ultra low. And they treated them with T-DXd or treatment of choice. And the primary endpoint was progression-free survival. And so T-DXd demonstrated a statistically and clinically meaningful improvement in progression-free survival compared with standard of care chemotherapy in the HER2 low population. And it demonstrated a statistically significant and clinically meaningful improvement in progression-free survival compared with standard of care chemotherapy in the intention to treat group as well. Progression-free survival improvement with TDXD versus treatment of choice chemotherapy in the HER2 low, ultra low population was consistent with the results in the HER2 low population as well. They also looked at dividing into these to other mutational statuses as well, and TDXD improved progression-free survival versus the treatment of choice, regardless of PIK3 mutation, AKT pathway mutation status, and regardless of ESR1 mutation status, as well as BRCA1/2 mutation status. So interestingly, there was a potentially greater benefit with TDXD in the mutation subgroup. And it confirmed overall response rate was improved with TDXD versus the treatment of choice group, regardless of PIK3, AKT pathway, ESR1, or BRCA1 mutation status. So Destiny Breast 09 is looking at HER2 positive advanced metastatic breast cancer. Asymptomatic inactive brain mets were allowed in this group. And so this was looking at TDXD plus a placebo or TDXD plus pertuzumab versus THP. And the primary endpoint is progression-free survival. And so far at this analysis interval, a statistically significant and clinically meaningful progression-free survival benefit was seen with TDXD with a mean change of 13.8 months and a median change of 13.8 months and a clinically meaningful improvement in progression-free survival with TDXD plus pertuzumab over THP in the investigator assessment group versus was also seen as a median of a change of 20 months. So both groups, as far as the BICR and investigator assessment, showed meaningful improvement. And for overall response rate and duration of response was greater in the TDXD plus pertuzumab group versus the THP group, I'm sorry. And as far as safety profile, the AEs were very similar in both groups. And so overall, the updates as far as take home and thoughts going forward, I would say that we have many treatment options for patients in the metastatic breast cancer setting. Some thoughts that come to mind is how we're going to use ctDNA to help track recurrence, progression, and detect mutations to guide treatment. We have some new generation oral SERDs and PROTACs available to us and on the horizon. And trope targeting ADCs are showing promise for progression-free survival and overall survival. And then also, prophylactic growth factor and loperamide may be useful in managing AEs on the sacituzumab regimens. Thank you so much for your time. And I hope that you were able to take away some meaningful information from this presentation.